Yeah,
Okay.
it's good.
All right, so this PowerPoint shows different scenarios of intensive care patients. Most of them are on ventilators and need ventilator changes. So we'll start off with the formula. When you're trying to predict the minute volume to give you a good CO2 in your blood gas, there's a formula that you can use. And you need to, in order to use the formula, you need to know the patient's current minute ventilation, the CO2 from the blood gas. You multiply those two numbers and divide by 40. It's usually 40 is the CO2 that you want on your blood gas, so that's why you divide it by 40. And then you'll come up with a new minute ventilation. So that new minute ventilation is what you'll target with your ventilator changes. Typically it's a change in the respiratory rate, but it could be a change in the tidal volume. If the tidal volume is not the 6 to 8 mLs per kilo, or 4 to 6 if it's ARDS. So we start off with ventilator settings of the PRVC mode with a rate of 10 per minute. Tidal volume is 650 ml. FiO2 0.3 and the PEEP is 5. There are no spontaneous respirations. The ideal body weight is 81 kilograms. It's a big person. And the ABGs are drawn. The pH is 7.34. The PaCO2 is 50 millimeters mercury. PaO2 is 100 torr. Bicarb 24 milliequivalents per liter. And the base excess is +2. All right, so I need you to interpret the blood gas for me. Okay, respiratory acidosis. Is it acute respiratory acidosis or chronic? Acute. And so the patient's on the ventilator, they're already getting a rate of 10 per minute, a tidal volume 650. So what can we do to get the CO2 in range?
Increase the rate.
All right, so increase the rate. Should we just guess at it and then get a blood gas, or is there a way that we could calculate what changes to make?
To find out what their current minute ventilation is.
Good, okay. So the current minute ventilation is 10 times 650. So 6,500 mLs or 6.5 liters. And the CO2 is 50 millimeters of mercury. Bless me.
Thank you.
So we want a minute ventilation of 8.1.
That's the new minute ventilation. All right, so you took the minute volume, multiplied by the CO2 from the blood gas, and then you divided by 40. And then when you do that on your calculator, it comes out to 8.1 liters. All right, so that's the new minute volume. So to keep going, now we need to know, we need the respiratory rate times the tidal volume to equal 8.1 liters. So now you have to use a second formula. I'll leave the lights off because I'm pretty sure you know this. So respiratory rate times the tidal volume, and we want it to equal 8.1 liters. Is the tidal volume that the patient is currently on a good tidal volume? So the way you do that is you take the tidal volume and divide by the ideal body weight.
It's 8.0. Oh, okay.
It comes out to 8 mLs per kilogram.
Oh, well, that's fine. Or is that 5%?
Yeah, that's another thing I noticed when you're turning in your patient assessments. And on the patient assessment form, it tells you to find the patient's ideal body weight and then decide if they're being ventilated within range of 6 to 8 mLs per kilogram. So what you do is you take the tidal volume on the ventilator, divide by their ideal body weight, and you're going to come up with how many mLs per kilogram they're being ventilated with. Does that make sense?
Mm-hmm.
So if they're being ventilated with 500 ml, and their ideal body weight is 50 kilograms, you would take 500, divide by 50, and you'll come up with a number, and that's how many mLs per kilogram. Does that make sense?
Yeah.
So you don't have to figure out 6 mLs per kilo, 8 mLs per kilo. You just take the tidal volume, divide by the ideal body weight, and that'll tell you how many mLs per kilogram are being ventilated with. So this, in this case, we'll take 650 mLs, divide by 81,
And it's
8 mLs per kilogram. So that's good, right? Should we keep the same tidal volume?
Mm-hmm.
All right, so now we've got another number here. So respiratory rate times 650 ml, let's put it in liters, 0.65 liters. So we have respiratory rate times 0.65 liters equals 8.1 liters. Now we have to find the new respiratory rate.
12.
Comes out to 12. So how do we get respiratory rate by itself? We divided both sides by 0.65. And that got us the respiratory rate all by itself, and it comes out to 12. Okay, everybody's all set with that? Okay, question? Caroline, are you okay? You're okay with both formulas, the first one and the second one? Okay. All right, so what are the issues in ventilating a patient that has neuromuscular disease? Well, typically they'll have pneumonia because they're so weak. Usually secretions are in their airways. They can't cough them out effectively. And anywhere you have secretions that sit, it's a perfect medium for bacteria to grow. So retained secretions usually get infected for that reason, and then a pneumonia starts. When you ventilate these patients, they typically have a normal lung compliance. So it's not like they have ARDS. It's typically normal lung compliance. They're pretty easy to ventilate. And then when you have them on the ventilator, you'll see that you've got good blood gases. Maybe you'll give them a couple days, and then you try to wean them. And when you're weaning them to see if they tolerate being weaned, we're so used to looking for, the respiratory rate's high, heart rate went up, the patient's agitated, or O2 sats are falling, they're not tolerating the wean. Well, a patient that has a neuromuscular disease, you don't see them express their inability to tolerate weaning because they don't have the energy to look short of breath. So they'll be short of breath, but they don't have the muscle strength, like the nerve and the muscle aren't communicating with each other. So they won't be able to be tachypneic. And you won't know that they're not tolerating it until you get a blood gas and you'll see the CO2s are high. So that's one of the things to look out for in patients with neuromuscular disease. They could look great prior to extubation, even on minimal pressure support, and then you take off the 5 of pressure support to extubate them, and all of a sudden they're not doing well. And it's because they had nicely compliant lungs, it's easy to oxygenate, and all they really needed was like 5 of pressure support to get a nice tidal volume. And when you took that away, now all of a sudden they're struggling. So what's really great for these patients is to extubate them and put them on non-invasive ventilation. So you're still giving them an inspiratory pressure to help, just like pressure support. A patient with Guillain-Barré syndrome is trached and has been vented for the past 18 days. Current ventilator settings, PRVC, rate of 10 per minute. The tidal volume is 550 ml, FiO2 is 0.3, and the PEEP is 5. The inspiratory pressure, or peak pressure, is 22 centimeters of water. The minute ventilation, 5.5 liters, and the total respiratory rate is 10 per minute. ABGs are normal. How would you proceed to wean this patient from the ventilator? What would you expect from weaning parameters that would tell you that the patient has a good muscle strength? So you do a negative inspiratory force, and you measure their negative inspiratory force. What number do you want to see? Less than negative 40? All right, so that's normal, but could we be a little more generous? Yeah, typically minus 25 or stronger or more negative. Yeah, so we're looking for at least minus 25. When you're doing a negative inspiratory force, if you do it during the first breath, you usually don't get the patient's best effort. To get the best effort, it's recommended that you occlude their airway for 15 seconds. To me, that's a little bit on the dramatic side, because yes, by 15 seconds of an occluded airway, they're going to be struggling, and you're going to get a very deep negative pressure. But the point is, at least 2 or 3 breaths. Don't just have them do it once and then write that value down, because they may not be participating as fully as possible, and you're not getting an accurate number. So to stress them a few seconds at least to get that extra effort, and then measure their negative inspiratory force. It also asks, would TP's trials be a good idea? A TP's trial means you take the patient off of the ventilator and just have an aerosol connected to the endotube or the trach tube, versus being on the ventilator.
I think you could go through the parameters first before doing a TPs. Like go to a spontaneous mode of ventilation first to see how they would do with a little bit of support, and then try a TPs.
Yeah, that's a great idea. So have them on CPAP with minimal pressure support, see how they do for a couple minutes, get your weaning parameters, and then if that looks good, you could try the TPs.
That's what I've seen them do.
Yeah, just keep in mind, a patient with a neuromuscular disease, when you put them on the TPs, you're not going to see tachypnea, and you're not going to see a great effort if they're in distress. So just keep that in the back of your mind. Auto mode, is that a good idea? Remember, with auto mode, you've got a full support mode and a CPAP pressure support mode. And if the patient's breathing spontaneously, they'll stay in the spontaneous mode. Or if they have a period of apnea, they go back to full support.
That'll be to be safe. Good.
To be safe? Mm-hmm. Yeah, and what if they're staying in auto mode all the time? because they're too weak to initiate a breath.
Put them on.
So, if they're not able to initiate a breath, then they'll just ride in full support the whole time.
Would you try SIMV?
SIMV with these patients, where you're giving them some breaths per minute? Yeah.
That way they work more than just, right on. Yeah, they have to work to get the air. Especially this patient is trached already, so.
Mm-hmm. And then just wean the rate, the SIMV rate every day? Okay, yeah, that's a good suggestion. What about BiPAP post-extubation?
Yes.
Yes. And then in my notes, I have use a heated humidifier with BiPAP to prevent drying of secretions. Have you seen heated humidifiers used at all?
No.
With the V60 or with the Vision? Yeah, I don't think I ever see that. It's a great idea. I mean, to provide humidification, especially with those fast flow rates that you're giving. But you're right, I don't see it. Here's a ventilator patient with respiratory distress. On SIMV mode, the rate is 10 breaths per minute. Tidal volume 750 ml. FiO2 is 0.4 and the PEEP is 5. Pressure support is 8. There's a peak flow rate of 50 liters per minute and with a decelerating waveform. When you look at the ventilator parameters, you see the peak pressure is 28 centimeters of water. The spontaneous tidal volume is 200 ml. It's kind of, well, is that small? The respiratory rate 35 per minute. IE ratio is 1:1, minute volume 11.5 liters. The patient assessment shows increased work of breathing with paradoxical respirations noted. So there's a lot of things that are flags here. That's a high minute ventilation. Fast respiratory rate.
Your IE ratio is 1:1.
Yeah. And then if they've got an increased work of breathing on top of it, they're paradoxing, they sure don't look like they should be in SIMV mode. What do you think of the blood gas?
Just hypoxemia.
Yeah, mild hypoxemia, but ventilation-wise, it looks okay. All right, see next slide for summary. There's a small tidal volume with pressure support of 8 centimeters of water, probably because the lungs are stiff. Patient is tachypneic. Could there be secretion buildup and low lung compliance? The PaO2 of 68 on 40% and PEEP of 5, that is a low PaO2. All right, so it tells us the problems, but it doesn't give us the recommendation. I guess that's up to us. What do you think we should do? Pull the plug?
No,
What?
She said full support.
Oh, full support.
We're gonna move on that easily.
You probably should suction though for the high PIP.
Okay, very good. Yeah, it's possible that we're seeing all of this because there's mucus plugs plugging up the airway. So suction first. If no improvement,
Change to full support
change to full support. Very good.
and maybe increase oxygenation of O2.
A PEEP?
Would we go up on the PEEP?
No, FiO2.
Yeah, so if we're at 60%,
Then it's okay.
then yes, go up on the PEEP. This moves us right along to the next case. What is the cause of hyperventilation? So we have a patient on a ventilator in full support, assist control mode. The rate is 12 per minute, tidal volume 700 ml, FiO2 0.6, and the PEEP is 8. Peak flow rate 60 liters a minute with a decelerating waveform. Ventilator parameters show the peak pressure is 28 centimeters of water, respiratory rate 35 per minute, IE ratio 1 to 0.8, minute volume 21 liters. Air trapping is noted. And there's normal work of breathing, really. But there is tachypnea. So what do you think about that blood gas? Yeah, what causes respiratory alkalosis?
Pain, stress.
Pain?
Is it electrolyte imbalance?
Oh, that's metabolic acidosis.
No, just kidding, no. Pain.
What else?
Ventilation, it's the tidal volume is high, 70.
Big tidal volume?
That's so separate.
So remember your list for all the things that can cause respiratory alkalosis? So fever, pain, anxiety, but what else?
Treatment should just pull it
I
out.
can't hear you.
Hang on.
Oh yeah, that's another one, head trauma. So if this patient had
Vomiting,
a case of head trauma, that could cause this.
Like lower, what about like lowering or not enough sedation?
All right, so like pain, anxiety from lack of sedation, yeah.
what about vomiting?
Would vomiting cause
You took all of that.
a fast respiratory rate? No, acidosis would cause a fast respiratory rate. But we don't have, we have a bicarb of 20. What about a leak in the circuit? An auto trigger? You said that?
Yeah.
Yeah, Ross said that.
Well, when you, oh,
I didn't say it loud.
She said it too low.
all right, so this could be also caused by a leak in the circuit, and there's auto triggering. Because obviously from the blood gas, there's no need for such a fast rate.
Yeah.
All right, some questions. Would you increase the set rate?
No.
No. Is the hyperventilation from a low PaO2?
No.
120? No, so it can't be that. Is the hyperventilation from a head trauma? I don't think we were given that information. No. Would you recommend sedating the patient? Would you?
If they're in
Yeah.
pain.
If they're in pain,
If
yes.
they're in pain, yeah.
Or anxiety.
All right, only if pain is noted?
Mhm.
Okay. Pain and anxiety. Would you check for circuit or airway leak?
Yes.
Yes. Okay.
Yeah.
All right, here's a question about sedation. A patient is on SIMV with a rate of 4 breaths per minute. So I guess they've been weaned down to a rate of 4. The tidal volume 500 ml. Pressure support is 10, FiO2 0.35. The total respiratory rate is 24 per minute with a total minute volume of 9 liters. The nurse informs you that she is going to sedate the patient. Is there a danger in continuing with the same vent settings?
Well, what kind of sedation
sedation should give?
Heavy propofol.
Okay.
Well,
So there is a danger.
Because it's gonna
Because it's at a rate
increase
of
your
4.
respiratory rate, and he's on SIMD.
Rate of 4, so if
So-
she's gonna sedate him, you have to
So you
increase
have to
that.
increase the rate or put him on full support,
Yes.
depending.
Yeah, so what other drugs beside propofol will suppress the respiratory drive?
Versa.
Precedent?
Oh, yeah, Clarissa.
I think
Yeah, Versed will,
Versed
I guess with a high
I
enough
think-
dosage.
Isn't Precedex is a little more
It
intensive?
doesn't
it doesn't.
affect it.
Right. Any narcotics?
Fentanyl?
Yes.
Yeah.
So fentanyl will decrease the respiratory drive.
And paralytics.
Muscle paralytics for sure. All right, we have a severe oxygenation deficit here. Patient on a ventilator in PRVC with a rate of 16 per minute, tidal volume 700, FiO2 is 0.7, and the PEEP is 15. The I time is 1 second. These scenarios are old. I don't know if you can tell that because tidal volumes were typically 700 to 900 when putting a patient on a ventilator. Yeah, typically 15 mLs per kilo was used. Yeah, so years ago, they started out with these really big tidal volumes, and yeah, a lot of people had ruined lungs from it. All right, so this person's already on an FiO2 of 70%, the PEEP 15. Peak pressure of 30, total respiratory rate of 16. Oh, that's probably from sedation. Minute volume is high. In the blood gas.
Compensated?
You're calling it a compensated blood gas?
Looks like it, or,
Is it like
Carbonate is
is a
a little
no, it's not compensated.
Well, the pH is in normal range,
Partially.
and bicarb is just 1 milliequivalent away from normal, so a high bicarb. So would you call it a metabolic alkalosis with compensation?
Yeah.
You could, yes. I agree.
And then there is a moderate.
What do you think about the 52 PaO2?
Moderate.
It's moderate.
And what would you like to do about it? It says to see the recommendations. Is the high minute volume causing respiratory alkalosis?
No,
So what is the minute volume?
11.2.
No. Our CO2 is up to 43, so we don't have respiratory alkalosis. Is oxygenation acceptable?
No.
It's
No,
52?
I mean, I guess it's acceptable. 60. Yeah, sorry, 60.
Would you increase the FiO2?
No.
So on 70% to go up to 80%, would your oxygenation improve?
Yeah.
Probably not. I mean, it looks like there's a lot of shunting occurring in the lungs right now, whether it's from edema, ARDS, and the oxygen just isn't getting into the blood. So to go up on the FiO2, usually you don't gain a whole lot with the amount that actually gets into the blood. Are you going to see this done at the bedside? Oh, yeah. You'll see 80%, you'll see 90%, you'll see 100%. But you'll notice that when getting up there, you don't see much improvement in the oxygenation because there's just so much shunting from the edema.
So when it says is oxygenation acceptable, you say no.
Oxygenation is not acceptable, no. 52 PaO2 and 88% sat.
Yes.
Yeah, we'd like to see 90%. 88% is still compatible with life, if we have to settle for that, if we've tried everything. It could still be compatible with life. Would you recommend a switch to bivent?
Yes.
Yes. So probably having those 5-second or 4-second inspiratory hold is going to pop open a lot of atelectatic alveoli and improve the amount of the oxygenation. So yes, you'd recommend switching to bivent. Would you recommend high frequency ventilation?
Yes.
Yes. So severe oxygenation defect is a reason to use high frequency ventilation. Now we have hypoxemia with a spontaneously breathing patient. A 50% aerosol T-piece is connected to an endotracheal tube of a patient who is breathing spontaneously. The SpO2 is low, and the physician asks you to place a PEEP valve at the end of the tubing where the airflow exits to the atmosphere. Would you do it? Explain your reasoning. So imagine a patient's intubated, they're on T-piece trial. They're set to 50% on the air entrainment dial, and their oxygen saturation is low. Whether it's 88% or 86% or whatever, it's low. So the physician is thinking, okay, if you stick a PEEP valve on the end of the T-piece, that'll create some PEEP, and then you'll improve your oxygenation. Would you do it?
I don't.
Is that even possible?
No. Yeah, if you put a PEEP valve on the end of an aerosol T-piece, you're stopping the flow from going past the patient. You're not going to create much positive pressure by doing that. You're just going to stop the flow back at the flow meter. So, no, you would not do that. All right, is this patient a candidate for weaning? A patient with normal lungs was treated for congestive heart failure, is currently on a ventilator